Sorry about that, team. We just had a bizarre stop to our broadcast, so we're going to continue. And so here, just to recap where we were, we've got this narrow complex tachycardia. It's fast, it's about 200 beats per minute. Narrow complex makes me think that it's utilizing the normal His-Purkinje system. And so because of that, I might think that this is a supraventricular tachycardia. It's very regular. And so, yeah, we'll call this SVT. Okay, let's go to our next. I'm actually gonna change my video. Okay, there we go. All right. So our next rhythm here, we've got, all right. Next rhythm, we're not gonna see the whole thing, but we see it's regular. It's happening regularly. We've got atrial activity for all of our beats. We can't tell exactly if it's a sinus rhythm or what, but what this rhythm is getting at is, there's no AV block. It's a wide complex QRS, and so what could cause QRS might maybe a bundle branch block. And if you look here in V5, V6, we've got our RSR prime in V5, V6, and we've got our deep S waves or deep negative deflections in V1. And so that R prime is late forces going into the left ventricle in this case because it's lateral RSR prime. So that would be a left bundle branch block. So we can call this a left bundle branch block. All right. All right, so next rhythm here. Let's take a look at the entire rhythm. We've got fast, fast, fast. Okay. Kind of irregular. What's going on? What's the atria doing? Well, we've got the sawtooth pattern. You can see it well in V1, always shows good atrial activity. And so these waves look very much like flutter waves. And these flutter waves are coming from the atria. We would call this atrial flutter. And so atrial flutter, we know we have to see how much it's conducting to the ventricles. And so see here we've got one flutter wave, two flutter waves, and three flutter waves per QRS. Here we've got one, two, three, four flutter waves for QRS. So this is variable conduction. Atrial flutter. And remember, the QRSs are going to be, driven by the AV node passing that signal down to the His-Purkinje system. And so we can still evaluate the QRSs for any other abnormalities. And so our QRSs are up in one, they're up in AVF, so we know it's going down and to the left. We've got a good R wave progression, no ST changes. So this is just atrial flutter with variable conduction. Alrighty. So here we've got beat, beat, beat. It's kind of normal, and then we've got a pause, beat, 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 beat. So you're like, well, maybe what is this pause from? And so you get some pause there, maybe a pause there. You just like a longer, see like longer and longer, and then shorter and shorter, and then longer. And if you look, you've got a P wave, P wave, P wave. These P waves are up in lead one. They're up in AVF, and so these are sinus P waves. And so if we look at what's going on here, P wave, they're conducting to the QRSs. The AV node is doing it at an appropriate speed. Blue. Sorry, guys, my cat is meowing like crazy. No. And so we don't have AV block. And if you look at these pauses, we got a P wave to a QRS. And then we have no atrial activity and then no atrial activity. And so this is actually just sinus arrhythmia in a person who's just young and healthy. And so this is due to changes in respiration, and whenever we increase the intrathoracic pressure by breathing in, we change the parasympathetic and sympathetic drive that we have on our heart. And so when we breathe in, we increase intrathoracic pressure. We have our decrease in preload, and we actually decrease our heart rate on our inhalations. So that's what's driving our sinus arrhythmia. Alrighty, so now we've got a regular rhythm. It's very slow. Looks like maybe 300, 150, 100, 75, 60, 50, probably somewhere in the 30 range. Okay, so what could cause this? Well, maybe it could be sinus brady, but it'd be very slow. And so I'm trying to think maybe this is a high degree AV block. So what's the atria doing? And I see P wave here, I see P wave there, I see a hidden P wave there, P wave, P wave, P wave, P wave, see another P wave. And so looks like maybe you can see the little hint of a P wave right there. And same thing right there. And so we've got P waves that are just marching through. And we have QRSs that are occurring regularly and not in any association with the P waves. So that tells me that the atria is trying to send signal down to the ventricles, but it can't. And these P waves are up in one, they're up in AVF. So these are sinus P waves, but the QRS is coming, it's narrow, it's coming from the junction. It's a junctional rhythm, and it's a third degree AV block. None of the P waves are getting down to the ventricles. And so you know it's a third degree AV block because those QRSs are occurring at a regular rate and they're very slow, and there's no conduction from the atria to the ventricles. So this is a third degree AV block with what I would call a junctional rhythm to keep us alive. So next rhythm here, we've got P wave conducts to QRS. We've got funky beat, P wave, QRS, funky beat, P wave to QRS. And so what are these funky beats? Well, they're wide, complex QRSs. And in front of them, I don't see any P waves. I see the T wave of our previous beat, but no P wave. And so this would be a PVC. And so if you look here, wide complex again. Here's the T wave of the previous QRS, but I don't see a P wave. So this is another PVC. So this person is having multifocal PVCs, and they're pretty mature. They're happening too early, right? If you look at this is the R to R interval, we would expect our next beat to be coming right around here, but it's not. So this person has multifocal PVCs. This is an interesting EKG, and let's take a look and see what we can get out of it. So we've got regular rate, funky beat, regular, 300, 150, 175, maybe 65 beats per minute. Okay. Okay, maybe kind of on the wide end, the QRSs are looking maybe 140 milliseconds, maybe a wide QRS. We'll get back to that. We've got P waves, and these P waves are up in one, and they're up in AVF. This is a sinus rhythm. Our AV node is working well. We have a normal PR interval throughout. And so if we look at our wide QRS, well, why is it wide? If you look at V1, we've got this RSR prime in V1 and V2. We've got these slurry S waves in the lateral leads. We've got slurry S waves in the lateral leads. And so that RSR prime, that R prime in V1, V2 is late signal to the right ventricle because the right bundle branch is blocked. So here we have a sinus rhythm with a right bundle branch block. Well, what about this funky beat? Well, this funky beat is a wide complex QRS that doesn't look the same as anyone else. There's no atrial activity in front of it, and so this is a PVC. So here we have a sinus rhythm, the right bundle branch block, and a PVC. Alrighty. Quick rhythm strip here. We've got an irregular rhythm, hard to tell what's going on, no pattern to it. What is the atria doing? Fibrillating. There's no organized activity. This is AFib. We've got narrow complex QRSs. That's what we would expect. We've got a funky looking QRS here, and that you might even say that that could be a PVC. Hard to say exactly, but I'd say maybe that's a PVC, and PVCs can still happen in AFib, because remember, AFib is just the atria is quivering, and the ventricles are only going to contract whenever the AV node sends that signal down, and so the PVCs can still occur in AFib. Okay. Here we've got a regular rhythm. We've got a rate of 300, 150, 100, 75, so maybe 80 beats per minute. And so we got P waves that are upright in one, upright in AVF. So this is a sinus rhythm. We've got normal PR intervals. We've got narrow QRSs that are upright in one, upright in AVF. So we know there's a normal axis. We have normal QT intervals. We've got normal R wave progression throughout, and no ST or T wave abnormalities. So we have this one Q wave in lead 3, but I wouldn't worry about that because the rest of the inferior leads look good. And so this is just a normal sinus rhythm. So we have a rhythm strip here, and what we've got is QRS, QRS. See what the red's better. QRS, QRS, and kind of a pause. QRS, QRS, kind of a pause. QRS, QRS. Maybe you would say this is group beating. So if we look at the groups, we've got P and then a QRS, P and then a QRS, but it's taking longer, and then a P with no QRS. PQRS, PQRS that's taking longer, the PR interval is lengthening, and then P with no QRS. And so not every P wave is conducting to a QRS, so we know this is second degree. And because those PR intervals are lengthening every single time, we can go ahead and say that this is second degree type 1 or Winky-Bach. Okay. So here we've got a wide complex rhythm. So wide QRS. It's greater than 120 milliseconds. And we've got these P waves that are just kind of marching through. And if you look even, there's probably a P wave notched right in that T wave right there, because this T wave doesn't look like it has that. And so we've got P wave, P wave, P wave, P wave. It's probably a P wave somewhere buried in this QRS, P wave. And so we have P waves that are occurring at regular intervals, and we have wide complex QRSs that are occurring completely irrespective of that. And so we have a regular ventricular rhythm that is slow, and we have a regular atrial rhythm that is fast. And so this has complete AV non-communication. And so we have here a third degree AV block with ventricular rhythm. So this is not a junctional rhythm, because junctional rhythms would be narrow, ventricular rhythms would be wide. And so this person's heart is beating off of a potentially a ventricular rhythm. And so, you would like to think this person has a pacemaker. If so, I would see maybe a pacing spike before, but I don't see pacing spikes. So maybe that's just me not seeing any pacing spikes, but you tell me if you see any pacing spikes there. Okay. So here we have beat, beat, gap, beat, beat, beat. And so let's look at what's going on. We've got P wave, QRS, P wave, QRS, okay. And then I don't see any P waves, and all of a sudden, P wave again, QRS, P wave again, QRS. And so this is a what I would call a sinus node is not beating, and so this is a sinus pause. Right, this is not a sinus node that beat and created a P wave that didn't conduct. It wasn't a blocked P wave, but there was no sinus node activity. There was no atrial depolarization, so I'd call this a sinus pause. Okay, so here we've got regular rhythm. QRSs are borderline wide, getting wider. The rate here is 300, 150, 100, 75, maybe 75 beats per minute-ish. And look at our PR intervals, what our AV node's doing. Actually, we'll look at our sinus node first. We've got upward P waves in AVF and kind of isoelectric P waves in one, so it's probably going down. Call this a sinus rhythm. And then you look at the PR interval, and these PR intervals are short. And what's the cause of short PR intervals? Well, if you look and you look through the rest of the leads, you see this is kind of a slurry upslope, a little slurred upslope, and so I'd call that delta wave. I'd call this Wolff-Parkinson-White. Okay. So we've got tick, 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 early, tick, tick. And each of these normal QRSs that are narrow have normal P waves in front of them, normal AV node function, P wave, QRS, and then this P wave looks different than the rest. These ones are nice and just upright P waves, and this is kind of a negative deflecting P wave. It's happening early, and that change in P wave morphology tells me that this is a premature atrial contraction and this ectopic, right? These are all going to be ectopic, meaning that they come from a different location in the atria. And so there was some ectopic beat that occurred early, so premature atrial contraction. The AV node picked that signal up and sent it down to the ventricles like it typically does. And then there's a bit of a compensatory pause as the sinus node takes its time to reset. And when it resets, it starts beating again, and we have normal sinus rhythm. So this is a sinus rhythm with a PAC. Okay, here we have a slow bradycardic rhythm. We've got 300, 150, 175, 60, maybe 52 beats per minute. I don't see any atrial activity ahead in front of it, but I see maybe these retrograde waves. They could be retrograde P. These are narrow complex QRSs, so this is a junctional escape beat or a junctional escape rhythm, and that's our rhythm. So here we've got um, this slow rhythm, and then we've got pause, and then kind of back to the normal. And so here we've got P waves in front of our QRSs, and then we've got pause, and then we've got different looking P waves. And so there's a chance that we have maybe two different morphologies of our atrial activity. And so I would say one of these must be an atrial escape rhythm. However, it's hard to tell which one is the escape rhythm because we don't have all the leads, but we would say that this is at least multifocal in origin. There's two different P wave morphologies, so the atria has two different focuses that are beating, and the QRSs all look the same because the AV node is still doing what we would expect the AV node to do. All right, so we've got normal rhythm here, and then we've got this early beat. So let's take a look at the early beat. The QRS looks the exact same from the previous one, so we know it's probably coming from at least through the His-Purkinje system. And we've got normal P waves previously, but this one doesn't have a P wave in front of it. So without a P wave in front of it, but a narrow QRS that looks just like the same, it's still using the His-Purkinje system to create that narrow QRS. So this must be a junctional escape beat or a premature junctional contraction, PJC. Okay. So here we've got beat, beat, beat. And then it looks like a P wave that doesn't conduct. We've got beat, beat, P wave that does not conduct. So not all P waves are conducting, and it looks like there's maybe some groups that are being formed. And so this is likely a second degree AV block because not all P waves are conducting to QRS. And this PR interval, as we notice, is getting longer and longer until it doesn't conduct. And so this is second degree type 1 or Winky-Bach. Alrighty, here we have a regular rhythm, narrow, complex, 300, 150, 175, maybe 65 beats per minute. Narrow, complex, and we've got these sawtooth flutter waves. So we'd call this atrial flutter. The QRSs are going to be narrow because the AV node is just going to pick those flutter waves up occasionally and send it down to the ventricles. And so what's the ratio of flutter waves to QRSs? We've got 1, 2, 3, 4. So maybe I would call this, let's see, 1, 2, 3, 4, 5. I'd call maybe that fifth one right there. It's hard to say. So maybe 4 to 1 or 5 to 1, a flutter. All right, next rhythm here. So we've got this slow beating bradycardia. It's regular. And if you look, we've got P wave, P wave, P wave, P wave, P wave, kind of marching through. And each P wave, or each QRS seems to have a P wave. So this is a tricky rhythm in that each of these P waves is conducting to a QRS in a normal PR interval, and then you have drop, drop. So this could theoretically be a second degree type 2 AV block. The problem is we don't get enough P's that are conducting to the QRS to determine if those P waves, because we need the P waves, the PR interval to stay the same for a couple beats and then drop. So it's hard to say if this is a second degree type 2 or a third degree, maybe a block, which is also possible. And this could just be a junctional escape rhythm that just happens to be occurring right after a P wave every single time. So this is a hard rhythm. This would be something that you would want to evaluate further to determine if it's a high grade second degree or a complete third degree. Either way, this person needs a pacemaker. Here we've got a bradycardic rhythm. The rate is 300, 150, 175, 60. It's slow. It's a very slow rhythm. And so when you look at this rhythm, I see P waves, P wave, P wave, P wave. I don't see any other P waves throughout here because this is such a slow rhythm. It makes you wonder if there's missing conduction, but it's not. And the PR interval is prolonged every time. No drop beats. This is a first degree if you block. And so this is a sinus Brady with first degree AV block. Okay. So this isn't giving us the entire picture, but what we can look at, so we know that this is a wide complex QRS. We know that wide complex QRSs are meaning that ventricular depolarization is not happening through the normal His-Purkinje system. And so I want to focus on, well, what are some causes of that? Maybe a bundled branch block. And if you look at V2, you've got this RSR prime. You can kind of see this big R prime right here. Big R prime in V1, but definitely RSR prime in V2. We've got slurry S waves in the lateral leads, V5 and V6. And remember, right bundle branch blocks have late forces going in the vicinity of V1 and V2 because that right bundle branch isn't conducting signal to the right ventricle fast enough, and so the left ventricle is sending signal late towards the right via cell-to-cell communicating junctions, and that's causing that R prime to be late. And then this late slurry S wave in V6 that's dictating or showing forces that are going away from the lateral leads towards the right ventricle in a right bundle branch block. So this is a right bundle branch block. Okay. Next rhythm here, we've got bradycardic rhythm, narrow complex QRSs. We've got P waves that are kind of marching through. Look how small this T wave is. Look how large this T wave is. So there must be a P wave buried on that T wave. So we've got P, 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 P. So P waves are marching through. They're not telling the QRSs what to do. This is a third degree AV block. Okay. So here we've got a very slow rhythm. We've got a beat there, a beat there, we've got a beat there, and we've got atrial activity just marching through, marching through. We've probably got a P wave like right in there. Actually, there's the P wave right there. P, 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 P. And these beats. And so these are escape beats. And so this right here, we've got sinus node because those P waves are up in one and they're up in AVF. So the sinus node is trying to beat and tell the ventricle what to do. But the AV node doesn't work. And so this is another example of a third degree AV block with some escape rhythms trying to keep this individual alive. Likely coming from probably the junction, if I had to guess. Or at least close to the junction. So here we've got a regular rhythm. We've got a rate of 300, 150, 100, 75, maybe 80 beats per minute. We've got P waves that are up in one, up in AVFs. This is a sinus. We've got a normal PR interval. We've got a wide complex QRS that is greater than 120 milliseconds. And so we look and we see we've got this RSR prime in V1, this RSR prime in V2. We've got slurry S waves in the lateral leads, which is telling us that there are late forces going towards the right ventricle, and that only occurs in a right bundle branch block. So this is a sinus rhythm, the right bundle branch block. So here we've got a rhythm that is not regular at all, and there's no pattern to it. They're narrow complex QRSs is telling me that it's coming from the AV node, but wonder why. And so I'm looking for any good atrial activity, and I see some kind of they're just squiggles, and these are T waves that we also see some T waves, but this is AFib with rapid ventricular response because look how fast this is, 300, 150. This is all 300, 150, this is 160. And so this is very fast rhythms. This is AFib with RVR. This person would benefit from either rate control by blocking their AV node with maybe a calcium channel blocker like Rapamil or metoprolol, or you could sync cardio with this person with electricity. Next rhythm here, we've got a wide complex, my cat is meowing. So we've got a wide complex QRS. We've got this wide complex QRS, and it's very rapid. It's 300, 150 beats per minute, 150 beats per minute, wide complex, monomorphic. And so you can say here that this is monomorphic ventricular tachycardia. And we know that ventricular tachycardias are going to be wide complex because they're coming from a focus in the ventricle. And whenever it beats and that depolarization spreads throughout the ventricle, it's not going to take the normal His-Purkinje system. And so it's going to occur, it's going to take longer for that QRS to occur, and it's going to be wide complex. Okay. Next EKG here, a little bit blurry. That's okay. We've got, let's take a look at this. We've got tachycardia. This is maybe just faster than 150, maybe 170 beats per minute. Let's look at the QRS duration. I'd say it's a pretty wide, complex QRS. And it's hard to tell exactly, but it's pretty wide. It's very regular. And um, the telltale sign of a wide, regular, complex QRS is sometimes you see these little notches in the T waves. And those would be retrograde P waves that are occurring because this is a ventricular tachycardia. So the reason why I know this is a ventricular tachycardia is you see occasionally these notched T waves that are telling me that every once in a while that AV node is sending these ventricular depolarizations retrograde through the AV node and back into the atria where we're getting a retrograde P wave. And so that's something called AV dissociation and ventricular tachycardia. This is a tough one though. So you could argue that this isn't VTAC, and sometimes you could get fooled. But I would say, depending on the patient scenario, this would be VTAC. But this is obviously, given the clinical situation, you would want to make your assessment. Okay, so we've got beat, 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 gap, beat, 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 gap. I would say this is maybe group beating. You've heard me say that a lot. So it makes me think, maybe this is an AV block. We've got P waves that are conducting to QRSs, P wave to QRSs, P wave to QRSs, P wave to QRSs, and then P wave to no QRS. So these P waves are up in one, they're up in one, and they're up in AVF. So this is sinus rhythm. And those P waves, if you look, they're getting the PR interval is getting longer and longer and longer until it drops. And so this is a second degree type 1 AV block. Okay. So we know that's going on. That's why these are not conducting. It's a second degree because not all the P waves are conducting. It's a type 1 because the PR interval is lengthening over time. Let's look at our QRSs. Our QRSs are narrow. That's good. And they're up in one and they're up in AVF. But if you look here, look at lead 3, we've got some ST elevation. AVF, we've got some ST elevation. Lead 2, we have some ST elevation. And we've got some reciprocal depression in V2, maybe even in V3. We've even got a little bit of elevation here in V6, not as much, but definitely in leads 2, 3, and AVF. So I would say this person has an inferior STEMI until proven otherwise. And that might be the cause of maybe that AV block, or maybe that's just they live with that AV block. So individual has an inferior STEMI. Okay. So here we've got beat, 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 funky beat, 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 funky beat. So the normal beats are ticking away, and then you've got this wide, complex rhythm here. I don't see any atrial activity in front of it. This is the previous T wave for this QRS, and you can compare it to the other T waves, and they look the same. So this looks like a PVC. It's wide, different morphology, no atrial activity, PVC. You can see the same thing with this one. So these are multifocal, or excuse me, these are unifocal premature ventricular contractions. So here we've got a tachycardia. It's regular. We've got a rate of 300, 150, 100, so maybe 120 beats per minute. So we've got a tachycardia. We've got some P waves. Those P waves, though, are maybe isoelectric in one, but they're negative in AVF. And so if they're negative in AVF, that means they're going up. So these P waves are traveling from down to up. And so to me, that tells me that these P waves are not coming from the sinus node. They're coming from an ectopic location, probably somewhere in the inferior portion of the atria, and the depolarization is spreading. So if I drew my atria right here, and my sinus node is usually just like so, and my sinus node depolarizes down and to the left, there's probably an ectopic focus, like somewhere along here, that's spreading signal up and it depolarizes up. And so that's why you're getting that P wave that is down in AVF. And so this would be an ectopic atrial tachycardia. So we still need to evaluate our QRSs, and our QRSs are narrow, and then the rest of the rhythm is just normal. So this is an ectopic atrial tachycardia, and that's why I really drive the importance of looking at those P wave morphologies in AVF in lead one and determining what the axis of the P wave is. Okay, so right here we've got a rhythm. It's ticking away. Okay, so maybe changing a little bit in duration. That's all right with narrow QRSs, but if you look here, we've got an upgoing P wave. Right here, we've got kind of a flat P wave. Right here, we've got a downgoing P wave. So it's telling me that these P waves are coming from different locations within the atria every time. And so this is a wandering atrial pacemaker. So this is another rhythm here. And this is kind of a more difficult rhythm. We're actually just gonna skip this. This one would take me a while. We're trying to just roll through these. So here we've got a wide complex tachycardia. It is it is polymorphic in the sense that it doesn't stay the same. And if you notice, it kind of gets larger in amplitude and then smaller in amplitude, and then larger in amplitude and smaller in amplitude. And so this is a polymorphic ventricular tachycardia, or it could be torsades. And so this is just a specific type of polymorphic VTAC. Okay, so here we have another bradycardic rhythm. We've got P waves that are marching through, and these P waves are not conducting to QRSs every time. So we know there's some type of AV block. And I would say that each of these P waves is conducting to a QRS. It's hard to say. So you could say that this is a second degree type 2 AV block, or a high grade second degree block, where we don't even get to see, it's a type 2, we say that the PR interval stays the same every single time until it drops. That would be a second degree type 2, but we don't even get the opportunity because we only have one QRS per P wave, and then we get a couple different blocks. So this is really difficult in the fact that this could technically be a third degree as well. It could be a third degree, or it could be a second degree type 2, or a high grade. But I would say we probably need to refer this person urgently to a cardiologist to get a pacemaker regardless. All right. So we've got a regular rhythm. Rate is about 100 beats per minute. We've got upgoing P. We actually, I think no, we didn't do this one. We've got upgoing P waves in one, upgoing AVF. So this is sinus, TAC. We've got normal PR intervals. So our AV node's doing well. If you look, that P wave is kind of high in lead 2, and it's up in V1, maybe more than normal. So this looks like we've got some right atrial enlargement. And that's very, very positive spiky P wave in lead 2, which is what's showing that in this upward portion of the P wave in V1 to the right atrial portion. So right atrium is enlarged. We've also got some large R waves in V1, so maybe borderline RVH. That would make sense clinically, right? What would cause the right atrium to enlarge? Maybe the right ventricle being enlarged, and that would backflowing blood into the right atrium. So a lot of times when you see right atrial enlargement, take a look at that right ventricle and see if it's hypertrophied. And I would say, yeah, we got a little bit of both. And so here we've got sinus tach with some right ventricular and right atrial changes. So here we've got it's like a kind of a regular rhythm, and we've got narrow QRSs, we've got P waves that are up in one, they're up in AVF, so this is sinus. We've got normal PR intervals, so our AV node's doing well. We've got QRS is up in one, up in AVF, so it's a normal axis down to the left. We've got normal duration of the QRS, we've got normal QT intervals, and so this is just a normal sinus rhythm. So I think we already did that one too. So here we've got regular rhythm, narrow QRS, 300, 150, 100, 75, maybe 70 beats per minute. Okay. P waves that are upgoing in lead one, upgoing in AVF. So this is a sinus rhythm. We've got normal PR intervals, so there's no AV block. We've got a QRS that's up in one and also up in AVF, so we know the QRS axis is down to the left, and so that checks out. We've got R wave progression that is appropriate in the precordial leads. We have a QT interval that's normal, and so this is a normal sinus rhythm. So here we've got a regular rhythm. We've got a rate of 300, 150, 100, so maybe 120 beats per minute. So we've got tachycardia. We've got P waves that are up in one, that are up in AVF. So this is a sinus tach. We've got a normal PR interval and it stays the same every time, so no AV blocks. We've got narrow QRSs. I would say that the QRS is up in one, but it's down in AVF, and so that means that it's going up into the left, so maybe some left axis deviation. And then if you look closely at these QRSs, we've got some elevation in leads 1 and AVL. We've got some depression in leads 3, leads 2, leads AVF. And so on the AVF, you really measure in the isoelectric line right here, and then into the QRS right there, and it's depression. So we've got elevation in leads 1 and AVL. So maybe a lateral ST elevation with some reciprocal changes in the inferior leads. Okay, so here we've got regular rhythm. We're tacking along. We've got a rate of maybe 300, 150, 100, 75, 60, 50, say, beats per minute-ish. We've got P waves that are upright in lead 1 and upright in AVF. So this is a sinus bradycardia. Okay. If you look at these P waves in V1, look how negative they are. It's a large negative component to the P waves in V1. And if you go back and look at one of my lectures that I'll be posting about atrial abnormalities, we know that deep negative P waves in V1, V1 is capturing the negative portion is capturing the atrial component of depolarization for the P wave. And so this would be left atrial enlargement. And so that's one finding that we have here. Let's look at the rest. So we've got PR intervals normal. We've got narrow QRSs, but they're down going in one, isoelectric and AVF. So if they're going away from lead one and they're isoelectric to AVF, we know AVF is in this direction. So if it's isoelectric, it must be perpendicular to that. And if it's negative in lead one, it must be going away from the camera in lead one. So this is some right axis deviation. If you look at the QRS morphologies, there is almost RVH, but maybe not. So this person has some interesting conduction disturbances. They've got some T-wave inversions in V1 through V3. And so this person maybe has a non-specific change in their axis, but they've got right axis deviation. They might have hypertrophy. It's hard to tell, but they've definitely got left atrial enlargement. And if that's the case, you want to investigate maybe some other causes to that atrial enlargement. So this person will probably do well with an echo or some clinical correlation. So here we have a normal rhythm ticking away. Narrow QRSs. The rate here is 300, 150, maybe 110 beats per minute. Tachycardic. We have P waves that are up in one and that are up in AVF. So this is a sinus tach. We've got PR intervals that are normal. So that's good. And if you look at this patient, we've got an axis that is down in lead one for our QRS, down in AVF. So that means it's going up and to the right. So that is very extreme deviation. And if you look in V1, we have these very large R waves that are greater than 7 millimeters. So this person has right axis deviation. So this person's got sinus tach, right axis, or excuse me, not right axis deviation, right ventricular hypertrophy. So some person has sinus tach with right ventricular hypertrophy as evidenced by these large positive forces that are in the V1 distribution capturing that right ventricular hypertrophy. Okay. Um, we've already done this one as well. So here we have a EKG that's got a regular rhythm. It's got a rate of 300, 150, 100, maybe 90 beats per minute. We've got P waves that are up in one or up in AVS. This is sinus. We've got normal PR intervals, so our AV node is doing well, conducts every time. We've got narrow QRSs, and if you look, maybe some deep S waves and high R waves in V5, V6, and so maybe this person has got ventricular hypertrophy. It's hard to tell. Um, if you look at the axis, it's isoelectric in AVF, positive in lead one. So the axis is a little bit more leftward. It's actually a little bit more negative than positive in AVF. So it's just barely up and to the left. So maybe some leftward deviation, not left axis deviation, maybe some leftward. And so we can count here and we can say 5, 10, 15, 20, 25 millimeters is the R wave in V5. We add that to the S wave in V1, which is 5, 10, maybe 15. 15 plus 25 is 40 millimeters. And so this person meets the criteria from an electrocardiogram for left ventricular hypertrophy. This is a sinus rhythm with LVH. So here we've got a normal regular rhythm, tacking away 300, 150, 100, 75, so maybe 80 beats per minute. We've got P waves that are upright in one, they're upright in AVFs. This is a sinus rhythm. We've got a normal PR interval. Look at these really heightened, spiky P waves in lead 2. And you can see there's a pretty good upward component in V1, but definitely this in lead 2 with diagnostic of right atrial enlargement. And so we know right atrial enlargement is, best characterized by the right atrial portion of depolarization, which is usually going more down and to the left, which is perfectly captured by lead 2. We also have for our QRS, we've got a downgoing QRS in lead 1, upgoing QRS in AVF, and so that would be going down and to the right for our axis. So we've got right axis deviation. And so we might have right axis deviation, maybe due to right ventricular hypertrophy, but we don't meet the criteria for that. And so here we've just got a sinus rhythm with right atrial enlargement, right axis deviation. So here's an example of they just zoomed us into V1 through V5. And if you want to see here, we've probably got some hypertrophy. And so if we measure the R wave in V5, we've got 5, 10, 15, 20, 25. And the S wave in V1 is 5, 10, 15. So this is actually the same EKG we just looked at. 40 millimeters LVH, because the left ventricle is captured by lateral leads. We know lateral leads include V5. And then the negative S wave on the more anterior right-sided leads are showing all of those electrical forces going away from the right side into the left ventricle. And so that's why I kind of point at these big S waves. All right. So here we've got a regular rhythm. The rate is maybe 300, 150, 100, 75, 60 beats per minute. Okay. We've got P waves that are upright in 1, upright in AVF. So this is a sinus rhythm. We've got normal PR intervals, so there's no AV block. Our QRS axis is up in 1, it's up in AVF, so we know our axis is going down to the left, so that's good. And so here we start looking at narrow QRS. We've got maybe some T wave abnormalities and V1 through V3, maybe some T wave inversions in those leads. Otherwise, this is a normal EKG. So if you remember what syndrome that you can see symmetrical T wave inversions in those V1 through V3 leads, might be like a Wellens syndrome. Okay. Nice, hi Frankie. My cat saying hello. Okay, so here we've got regular rhythm. Rate is 300, 150, 100, maybe 140 beats per minute. We've got P waves that are kind of sliding in. They're upright in 1. They're upright in AVF. It's a sinus tachycardia. We've got a PR interval that is right at the upper limit of normal. We've got our narrow QRSs, but they're upright in lead 1, and they are isoelectric in AVF. So maybe this is probably a 0-degree QRS axis. If you look, what you'll notice is you'll see as we kind of look through the ST segments here, we've got some ST depression in lead V4, V5, V6, V3, V2. We've got some elevation in AVR. Got some depression here. So we've got some diffuse depression with some elevation in AVR. And so I think clinical correlation would probably benefit this patient and determine if this is an ischemic cause of their ST changes. Okay, so we get another rhythm here. Somewhat normal, but not really. It's kind of narrow. It's kind of wide. Looking for what the atria is doing. Can't see, sometimes you feel like you see a P wave right there. Sometimes you see my P wave there, a P wave there. Maybe a P wave there. It's hard to say. So it's kind of a difficult EKG here. They're narrow QRSs, and that's okay. So we know the conduction is going down the AV node. And so this is one of those EKGs where you could say, yeah, maybe this is AFib. It's an irregular rhythm. I don't see good atrial activity. You could say that maybe there is atrial activity, but there's variable conduction through the AV node. But I would say that that's not really the case. I personally would call this AFib. What I would do is I would get a longer rhythm strip to determine if, what this person's um, rhythm strip looks like, and if it looks like they're an AFib, or if there's maybe a more predictable pattern. And so a couple other things I want to show you in this EKG is there is some depression ST segment in lead 2, and there's some elevation in AVR, which is usually reciprocal to any depression changes that you see. And so, yeah, I would love to maybe investigate why they have a little bit of depression there. Okay, so here we're just going to look at some of these ST changes here. We've definitely got ST elevation in lead 1, ST elevation in AVL, and we've got massive elevation in V2, V3, V4, V5, V6. And so we know that V5, V6, AVL, and lead 1 are lateral. We know that V4, V2, V3 are anterior. So this is anterolateral ST elevation with some reciprocal changes with ST depression in lead 3. Maybe some in AVF, definitely some in AVR. So that would be the reciprocal depression that we see. So we've got some anterior lateral STEMI here. This is an interesting EKG. So take a look at it. We've got a regular rhythm here. The rate is maybe 300, 150, 175, 60 beats per minute. We've got P waves that are upright in 1, upright in AVS. This is a sinus rhythm. We've got a PR interval that we'll call normal. It's around the upper limit of normal. The QRSs that are on maybe a little bit on the wider side. So let's try to figure out why they're on the wider side. And if you look, this is a really hard one to see. But when you see these kind of wide, slopey upward in V6, you can almost believe that there's an RSR prime up there. I almost believe there's an RSR prime, RSR prime. Lead 1, it's like a RSR prime. And same thing with AVL. And so this is maybe a very subtle left bundle branch block. To get more evidence to that, we can see that we have lost our septal R wave in V1, so no septal R wave. And we know that the septal R wave comes from the left bundle branch, and if the left bundle branch is blocked, then we're going to lose that septal R wave. We're going to have these deep slurry S waves instead. And that's indicating those late forces going towards the left ventricle since the left bundle has been blocked. And so I would say this is a sinus rhythm with a left bundle branch block. You could argue that if the QRS is wide, we would call it a left bundle branch block. Okay. We already done the EKG. All right, so another STEMI here. We'll just look at the ST segments real quick. So here we've got elevation V1, V2, V3, V4, V5, maybe a little bit in V6, but definitely throughout the anterior leads, and even a little bit of elevation in lead 1, so some in AVL. Got some depression in AVF, depression in lead 3. And so that would be what we call reciprocal depression. Another STEMI. Let's take a look at what we see. We see elevation in lead 2, elevation in lead 3, elevation in AVF. So we've got elevation in the inferior leads. We've got depression in V1, depression in V2, depression in V3. And we've got elevation in V6, maybe a little bit of elevation in V5, Mainly the elevation is in these inferior leads, so I'd call this an inferior STEMI with reciprocal changes in the anterior leads. Okay, we're not going to go over this. This is a left anterior hemiblock. We're not going to go over what that means because I think that's just not in the cards yet. This is a left posterior hemiblock. If you want to look at what those are, it's essentially the hemi blocks or the hemifascicles of the secular block, all synonyms here. Those are branches off of the left bundle branch that will penetrate into different aspects of the left ventricle. And so if these are blocked, you can get some interesting morphologies. Already looked at this one. Let's see here. Here's some big ST changes, what we'd call tombstoning. So if you look at V1, we've got large ST elevation. V2, it's so large ST elevation that's like a tombstone. V3, it's a tombstone. 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 And then you've got reciprocal depression in lead 3, reciprocal depression in AVF, reciprocal depression in lead 2. You've got elevation in AVL in lead 1. So this person's having a diffuse STEMI, big, large left ventricular infarct. Alrighty. So here we've got a rhythm that's kind of irregular. We've got it kind of just beats all over the place. You've got P waves in front of that one. P waves in front of that one, but they're downward, upward, upward but different, upward but different, upward but different, kind of flat, downward. So we've got multifocal atrial activity in this, and so we would maybe call this a wandering atrial pacemaker. I can call it a wandering atrial pacemaker because the QRSs remain narrow and the same. So I know that the AV node is just taking the signal from the atrial depolarization and sending it to the ventricles. But because the P wave morphology is different, it tells me that the focus that is what is driving that atrial depolarization is coming from a different location. Here we've got a regular rhythm at a rate of 300, 150, 175, maybe 70 beats per minute. Narrow complex QRSs, P waves for every QRS, good PR intervals. This is just a normal sinus rhythm. Here we've got a narrow complex, rapid, regular tachycardia that's happening at maybe 200 beats per minute. It's a narrow complex, so it tells me it's going through the AV node down the His-Purkinje system. And I don't see any really discernible atrial activity that would explain this. So this is supraventricular tachycardia. Okay. Here we have a regular rhythm. Rate is 300, 150, 175, so 75 beats per minute. We've got P waves, but that PR interval is really short. So when I think of PR intervals being really short, I think of maybe some pre-excitation. If you look, we've got these slurry delta waves, And so this would be a pre-excitation, Wolff-Parkinson, White, which we know is a extra communication between the atrium and the ventricles that bypasses the AV node. And so if the AV node is what usually slows the conduction from the atria to the ventricles and what allows for that PR interval to exist between 120 and 200 milliseconds, then when you have a pre-excitation channel, the PR interval is going to get a little shorter. So that's why we see a short PR interval there. Okay. So here we have a regular rhythm just ticking away. The rate is 300, 150, 175, maybe 70 beats per minute. We've got P waves that are up in 1, up in AVF. This is a sinus rhythm. We've got normal PR intervals, so our AV node is happy. Our QRSs are narrow. They're up in 1. They're up in AVF, so they're going down and to the left, which is normal axis. We've got normal R wave progression throughout the precordium. We've got no ST or T wave abnormalities, um, no QT interval prolongations. This is just a normal sinus rhythm. So here we have a rhythm that is kind of irregular. It's like pause, quick, slow. What's going on here? Do we see any good discernible atrial activity? I see some kind of fibrillations. Not quite sure if I have any good P waves. This is atrial fib. Why do I know it's AFib? Well, the QRSs are narrow, so I know if they're narrow that they're being conducted down the AV node through the His-Purkinje system into the ventricles, and so our QRS is going to be quick and narrow. And so I can infer because of that that this is likely an arrhythmia that's arising from the atria, and I don't see any good atrial signal, and so this would be AFib. Here we have a wide complex tachycardia, and you can see these QRSs are very wide, they're very regular, they have the same morphology the whole time. And so I would say the rate here is 300, 150, maybe 200 beats per minute. Wide complex. Well, what would cause a wide complex tachycardia? Probably something that is not taking the His-Purkinje system route, so it's not coming through the AV node, it's coming from an ectopic focus in the ventricles, and so this will be monomorphic VTAC. Okay, and this is our last one, guys. So here we've got a regular rhythm. The rate is maybe 300, 150, 100, 75, 60, maybe 65 beats per minute. Not exact. Let's look at our atrial activity. We've got upright P waves in lead one, so we know it's going to the left, but downgoing P waves in AVF, so that means it's going up and to the left. This is the P wave. It's going up and to the left, so that's not a sinus P wave. It is not a sinus P wave. A sinus P wave would be going down and to the left. And so we would say that this is um, an ectopic atrial rhythm. And remember, the QRSs shouldn't change in this case because the AV node is just conducting the signal that it receives. And so it doesn't know if it receives signal from the sinus node or from an ectopic beat. And so we still have narrow QRSs throughout. Our QRSs are isoelectric in AVF and they're up in one, so they're probably right at about 0 degrees for our axis, which is normal. And maybe a little bit of premature RF progression, that's not a big deal. Maybe borderline QT prolongation. If you look, it's a little bit over. And so, yeah, you could maybe argue that the QT is prolonged, and I would say that you should probably calculate at this point. I'm not going to calculate it. And so I would say that this is a ectopic atrial rhythm. You could say an atria escape rhythm. And um, otherwise, maybe prolonged QR or QT. So with that, we are done with our EKGs. Remember my approach. Look at the forest. Look at the overall rhythm. Is it regular? Is it irregular? Start forming your differential. That's what we need to do here is we need to form a differential diagnosis. Are the QRS is narrow or wide? That's going to help you change your differential. What is the atria doing? Are the P waves there? Are the P waves in the morphology that would tell you that it's coming from the sinus node? And so you need to look at that. You need to look at the intervals. What is the AV node doing? Is that's the PR interval? What is the QRS axis? Q waves that are pathological, and just put everything together. So that's my approach. Formulate your own, and have a great day.